At the outset, I would like to thank the organizing committee for such a wonderful hospitality and for having me here. Well, the latest fad or the latest papers on peritoneal dialysis would be talking about the topic which I'm going to say, and that is incremental peritoneal dialysis. I would be briefly covering it in the outline of definition. What are the advantages? What is the evidence? How practically we can start a patient on incremental PD? What are the challenges? And finally, just to refresh everything, just end up with some case scenarios which are real world or real time case scenarios. Well, we all know that the current ISPD guidelines has actually pushed us towards now more high quality personalized peritoneal dialysis as opposed to the previous solute clearance dependent peritoneal dialysis. And this obviously is driven by a lot of evidence which actually has shown that after a particular ceiling, there is no point of increasing clearances any further. We have a lot of trials. We have EDIMAX, we have Hong Kong trial, we have even the study from Canusa, which actually shows that after a certain point, there is no further advantage of increasing clearances any further. And this is what pushed the ISPD to have a guideline suggesting that improving patient experience and providing high quality goal directed peritoneal dialysis remains the ultimate goal of keeping a patient on PD. Fortunately or unfortunately, the idea of incremental PD is actually not new. Unfortunately, it got buried down in the developed world for so many more reasons. And this was first described in the erstwhile NKF DOCI PD guidelines. As very rightly pointed out in the previous session, we in the developing or underdeveloped world had the privilege of actually practicing the process of incremental PD, incremental hemo for a long period of time because of various other constraints. So now coming on to the definition of what is an adequate PD. Well, we know that clearances wise we have a KTV over urea of more than 1.7 and a creatinine clearance of more than 45 liters a week. As I said, we have some evidence to say that anything below 1.5 or maybe 1.6 is harmful, but beyond 1.7, achieving clearances is not a huge advantage. We basically now aim to have improved quality of life, decreasing the treatment burden, and have a shared decision making between the patient and the caregiver. And the parameters which now are included in adequacy of PD include high health-related quality of life, the volume status, the nutritional status, and obviously still the solute clearances. So, incremental peritoneal dialysis is basically a concept rather than a prescription. It might vary from patient to patient. It might vary from a prescriber to prescriber. And as I said, it basically depends upon the shared decision making between the patient and the caregiver. So, by definition, any prescription which is less than a standard dose, and this standard dose again would be different for the Caucasians and for the Asian population. For the whole of the Western world, it's less than 4 cycles of CAPD a day, while for South Asian population, it still is 3 cycles a day. But the most important caveat is with an intent to increase if needed. So, here the role of the residual kidney function is paramount, and as the residual kidney function goes down, you would have to increment your PD with more exchanges. It's also important to realize that what is not incremental PD. So, say I am starting dialysis for a patient in whom I have no intent of increasing the cycles further. I am starting off with a low dose, but I have no intent of increasing the cycles further. This could be because of the economy. This could be because of the overlying condition of the patient. He might be comorbid. We might be just giving a palliative care by giving incremental PD. So all these are not incremental PD. Or we have to do an urgent start PD. We start off with low cycles and then subsequently increase our duration of cycles and the number of cycles. So it's important to realize that financial palliative care or urgent start PD don't fall into the preview of incremental PD. And how common is intermittent PD? Well, as I said, if we say in the hall right now, how many of you would having a PD patient who would be doing less than 7 days all cycles, a APD patient who keeps himself day dry, or a CAPD patient who would do less than 3 cycles a day? Again, they all would be incremental PD. Quite a few of us actually have been doing it, as I said, for various reasons. But if we see the Western data, this is from the various countries, and we see that around 1/3 of the patients would be on incremental PD in Japan and Australia. The numbers are much lesser in US and Canada. In US, obviously, it's driven by the quality of dialysis they deliver, and they have to achieve this much of KT over V to have adequate medical reimbursement. But for APD, it's still much more common. So to the tune of 35 to 50% would be on incremental PD on an APD prescription. So what could be the advantages of incremental PD? Chairperson did highlight a few. So obviously, you have some advantages which are quite obvious, which don't require any proof. Because you would be doing lesser number of cycles, you would have more time for productivity. You would have lesser burden of dialysis. There would be lesser anxiety because you would be more free for your other day-to-day activities. And because you would be having either the lesser volume or less number of cycles, there are less chances of mechanical complications and dyspepsia. It obviously would be cheaper, and it obviously would be more friendly towards the environment. It would be more form of a green dialysis. So this is a data which basically looks at in the Australia and New Zealand, this basically looks at the quality of life and incremental PD. It basically looks at patients on incident PD with a propensity matched pairs both in CAPD and APD. They had around 800 patients, so 400 such pairs, and they followed up for 12 months for clinical and quality of life outcomes. And they found that incremental PD was better on 3 scores of physical composite, burden of kidney disease, and effect of kidney disease, though there was no difference in hospitalization and mortality rates significantly, though they were numerically lower. This study basically looks at the effect of incremental PD and the environmental benefits. These had patients who did a single exchange, 2 exchanges, 3 exchanges, and 4 exchanges a day. And it requires no rocket scientist to know that the patients on incremental PD had lesser glucose exposure and more free time. To put it in numbers, on an average, 1 less PD exchange a year results in 4 months of additional cost for PD, 47 to 75 kgs less plastic waste, and obviously decreased carbon footprint by less deliveries and water use. So obviously, it's a greener form of dialysis. There are certain advantages which looks obvious but are not proven and a bit more difficult to prove. We believe that by keeping the peritoneum dry, we are actually increasing the host defense of the peritoneum against peritonitis. So these patients should have lesser infections. They have lesser number of connections and disconnections to do, so obviously touch contamination should obviously be lower. Since they are exposed to lesser number of glucose and GDP products, they should have better preservation of residual renal function. And this, both of them together, should result in improved patient and technique survival. However, unfortunately, we don't have appropriate studies to prove these benefits of incremental PD. We only have one small single center RCT from China, which compares incremental PD with the standard PD prescription. We have few observational studies and data from some centers, and more recently, as I just highlighted, we have propensity matched cohorts from various registries, particularly ANZ. So just highlighting few important trials in incremental PD. This is the randomized control trial I was talking about. It basically recruited around 140 patients and had a 2-year follow-up. It was done long time back, 2004 to 2008. And the target was to either attain a KT over V of more than 1.7 and uremic symptoms. So not really what we are aiming as far as the high health-related quality of life goal-directed PD is concerned. Out of the 70 patients randomized to incremental PD, 12 patients needed an addition of a fourth well. So it was basically 3 versus 4 exchanges a day. What they found was there was no difference in anuria-free survival, estimated GFR, and urine volume in these two groups. The patient on incremental PD had lower KT over V and lower ultrafiltration, which again is not unexpected. But if you see at the numbers, they were targeting more than 1.95 and 1.7, and they achieved 1.95 in incremental PD and 2.2 in patients on standard PD. The ultrafiltration again was around 404 for incremental PD versus 742 by conventional PD. But the patients on incremental PD had longer peritonitis-free survival and fewer peritonitis rates, though it was still statistically not significant. This is a study from India. Dr. Tarun Jaloka from Pune basically did an interesting study. He offered all patients who presented to him with a urinary KT over V of more than 1 and were indicated to start dialysis, he offered them either one exchange of icodextrin a day or conventional CAPD. So it was not a randomized control trial, it was sampling of convenience. And he assessed the adequacy at 1, 3, 6 months and then 6 monthly. And he shifted the patients to conventional PD if he didn't have adequate adequacy, which again was not described, or if the patient had clinical indication to intensify his dialysis. The median period for ICO alone was still 9.6 months. The patients had much lower peritonitis rates, much lower exit site infection, and there was much better patient as well as technique survival. This is another ANZ registry data, which basically looked at all incident patients for a decade, 2007 to 2017. And they looked at incremental PD, which was defined either as an exchange volume of less than 42 liters a week or more than 42 liters a week, which was standard. What they found was that incremental PD was associated with reduced peritonitis risk and lower incidence of 30-day transfer to hemodialysis. So lower peritonitis risk and better patient survival and better technique survival. This is analysis from the BALANCE trial, again from Australia and New Zealand, which basically is a post-hoc analysis in which they have looked at the residual renal function slope decline in patients on incremental versus non-incremental PD. We all know that BALANCE basically looked at biocompatible versus bioincompatible fluid, and they, in this post-hoc analysis, didn't find any difference in the decline of the slope of the estimated GFR in patients on incremental or non-incremental PD. So what we do if we don't have evidence enough from data, we basically go to a meta-analysis. And this is a meta-analysis which is recently published in BMC Nephrology, which basically looked at outcomes of incremental versus standard peritoneal dialysis. It in total had 10 studies and only one RCT, which I have already highlighted. They found no difference in mortality, no difference in or any trend towards better or negative trial for mortality as far as incremental PD is concerned. Out of a total of 10 studies, only 8 looked at peritonitis, and a lower peritonitis rate was shown only in one study. Technique survival was studied in 6, and benefit was shown in one study. And anuria-free survival was studied in 3 studies, of which 2 showed better anuria-free survival in patient on incremental PD. So very fragile data, very small data to really go around with. But one thing I want to highlight here is it's more of a non-inferiority trial. We are doing lesser PD exchanges, we are giving lesser volume, we are doing lesser clearances, and still there is no trend towards increased mortality or decreased patient survival or technique survival. So this, in fact, is a very important, though this seems like a negative meta-analysis, this in fact is a very positive meta-analysis for if we have to interpret it for incremental PD. Now, if we really are convinced about incremental PD, how to start around by giving incremental PD? Well, by a rough estimate, around 50% of the patients at any given time who are dialysis naive and have to start PD, 50% would be eligible for incremental PD. This is irrespective of their membrane status. And if you have 2 dwells a day in a patient who has a urinary GFR of more than 6 liters per minute, you still would achieve adequate clearances. And we know that we are not only talking about solute clearance, we are not talking about patient-central approach and keeping patients fitter and longer on PD. I'm sorry if it has come this way. Okay. So basically, what are the factors which we see once we look at the prescription of incremental PD is, we basically have to look at the lifestyle of the patient, the residual kidney function, the membrane type, and the body size. And we have to decide upon the dwell volume, the number of exchanges a day, and number of free days which we can give a patient. So there can be multiple ways of prescribing an incremental PD. The most important thing while prescribing incremental PD is to monitor this patient. And that's where the problem starts. As a nephrologist, we are always busy. But once we start a patient on incremental PD, we have to actually follow them up more thoroughly every 3 months and look at multiple levels, not only about clearances, but also about volume and the health-related quality of life. So the biggest challenge, as I said, is the increased workload to the unit and the nephrologist. The second biggest challenge to incremental PD is the patient inertia. Once you start a patient on a lower exchanges, they become extremely resistant and have a huge pushback once you tell them to increase the number of exchanges or increase the volume of exchanges. Here, the trick which I follow is, every time the patient comes to me, every 3 months I will just hammer, so far, so good, so far, so good. This basically is a way to tell them that things are fine right now, but it's not for eternity. Sooner or later, you would have to bump up your PD prescription one way or the other. And the other important thing is the nutritional concerns. We are keeping the patient azotemic, we are having lesser clearances, so we have to assess their nutrition properly and follow their nutritional protocol. So as I promised, just to drive home my point, 2 cases which I had for quite some time now. The first is a 35-year-old female who had a lupus nephritis, went into end-stage kidney disease. She works as a data analyst, has a 9 to 6 job, 5 days a week, and she now needs a start in dialysis. She has chosen PD. What would be your prescription for this patient? Well, the prescription which I followed was, and I started it 2 years back, we did her PET status, she was high average. So the prescription which I followed was 2-liter night well of icodextrin, 5 out of 7 days. So she went to the office, she came back, she put in an ICO exchange. Morning, she disconnected herself from the PD, went to her office and did nothing in the office. And 2 days when she was off in the weekends, she would do the conventional PD of 2 1.5% exchanges and 1 night well. This way, we had a peritoneal clearances of around 1.5 and a urinary clearance of around 1.38, which sufficed for most of the time. Until now, for past 2 years, she is continuing. The urine output has dropped, but somehow she is still maintaining a total clearance of around 1.5 without developing any azotemic symptoms, and I have not bumped up the prescription. The second case is of a banker who is a 57-year-old diabetic. He also had a similar job profile, but he worked 6 out of 7 days. Again required initiation of dialysis. Had a baseline estimated GFR of, again similar to the previous patient, that was 6.8. What did I start off with? I started off with night alone APD, 2 liters, 5 exchanges, 10 hours, 7 out of 7 days. Again, initial adequate clearances of 2.1 by combining both the peritoneum as well as the urinary findings, as well as the urinary clearances. He unfortunately had to go an angiography. Subsequent to that, he had a significant decline in urine output, and then I had to shift him to icodextrin in the morning, and now he continues on APD in the night and icodextrin in the morning. So my last slide, just to conclude, incremental PD aligns closest to the current ISPD guidelines of prescribing high-quality, patient-centric, goal-directed therapy. The current evidence is limited by low to moderate grade studies. However, incremental PD gives us significant economic and environmental benefits and gives better quality of life. The outcomes are at least as good, if not worse or not better, than the full dose PD. It might preserve the residual kidney function for a longer period of time, decrease the peritonitis rates, which is still unproven, and it remains a viable modality for most of our patients at the start of therapy for around 12 to 18 months. However, it increases our workload by requiring a closer supervision and continuous counseling. Thank you.
So I'm going to be speaking on managing PD peritonitis. These are my disclosures. And then peritonitis is an extremely important cause of patients being transferred from peritoneal dialysis to hemodialysis, as well as an important cause of morbidity and mortality in our patients on peritoneal dialysis. In this 2006 analysis of the USRDS data, it's estimated that about 45 patients of patients in the United States had to transfer to hemodialysis due to infections or problems with the catheter. And it's not difficult to diagnose peritonitis when a patient comes to you with a cloudy PD effluent that you can see in the middle when you compare that with a new bag or a patient who has a normal effluent. And as trainees, we've been taught what's the definition of PD peritonitis, how do we diagnose PD peritonitis, and this is nicely articulated in the ISPD guidelines. So we need to fulfill at least 2 or 3 criteria. The first being that there are clinical features consistent with peritonitis. That means patient presenting with abdominal pain and or cloudy dialysis effluent. When we send the PD effluent for cell count, it should be more than 100 cells per microliter or more than 0.1 times 10 to the power 9 per liter. But there is a caveat to this that there must be at least a dwell time of 2 hours with more than 50% morphonuclear leukocytes. And 3, a positive dialysis effluent culture. So any 2 of these 3 will qualify for definition of PD peritonitis. However, I do need to highlight that while patients may present with abdominal pain and cloudy effluent, but we need to consider peritonitis even in the setting where the PD effluent is clear. And this is because of the patients not having an adequate dwell. And so you might not see a cloudy effluent, especially in patients on APD. And conversely, cloudy fluid can also occur even in the setting of minimal or no pain, such as those patients with a lesser sec peritonitis. And really the degree of pain is somewhat very organism specific. Patients with Pseudomonas peritonitis tend to present with a lot more symptoms, whereas patients with TB peritonitis may be actually asymptomatic in the beginning and on the onset of peritonitis. The ISPD guidelines was updated in 2022, and what some of the new changes to these guidelines is that they have put forward a few standardized definition for what is considered cause-specific peritonitis and as well as time-specific peritonitis. And the main purpose of having these standardized definition is to allow for easy comparison between studies, as well as easy comparison between units and registry data so that it becomes easy. So just to highlight a few, so for cause-specific peritonitis, I think it's not that difficult. I think if we have an organism, we want to name it a Pseudomonas peritonitis, for example, because certain organisms are a lot more aggressive and therefore it's important in clinical management. Culture-negative peritonitis is also important. I'm going to touch upon that later on. The other thing is catheter-related peritonitis. And this is peritonitis that occurs in temporal conjunction within 3 months of a catheter infection, either an exit site infection or a tunnel infection with the same organism at the exit site or tunnel and in the effluent, or there is at least one site that is sterile. So you could have a Staph aureus exit site infection and a Staph aureus peritonitis within 3 months that will then qualify as a catheter-related peritonitis. If you have a Staph aureus exit site, but you have a culture-negative peritonitis within 3 months, that will also qualify as a catheter-related peritonitis. And then enteric peritonitis will be defined as peritonitis arising from intestinal source, such as an inflammation like appendicitis, a perforation, or even ischemia. And then there's time-specific peritonitis, and this is important to help us to find the cause of the peritonitis and then deal with the root cause. So the first one is pre-PD peritonitis, and this starts from the day of the PD catheter insertion and ends with PD commencement, which is then defined as the time where PD is being planned to continue indefinitely. PD-related peritonitis will then start from the day of PD commencement and continues while a patient remains on PD, regardless of the setting, whether they're in the hospital, at a home, or regardless of who is performing the PD. And then, of course, PD catheter insertion-related peritonitis is basically peritonitis that occurs within 30 days of PD catheter insertion. So let's talk about how we diagnose PD peritonitis. We have a patient who is on APD for the past year without difficulty, now presents with fever, chills, and abdominal pain. The PD fluid is slightly hazy. However, the cell count only shows 75 cells per meter squared or 75 cells per microliter, 90% of which is polymorphonucleosides. But the exit site is perfect. So the question is, are his symptoms typical of PD peritonitis? What is really the diagnosis? And if this is PD peritonitis, why is the cell count only 75? And would you start antibiotics? If so, what? So just to close the loop, I know that APD, which is cycler-based PD, may not be that prevalent in Sri Lanka or in this part of the world, but there are some nuances when we diagnose PD peritonitis. And the diagnosis could really be affected by the timing of the effluent sample collection. So if you have shorter dwell time, such as in the cycler, you will have less time for the cell count to increase. And that's why to diagnose PD peritonitis, there is a caveat that's written in the diagnosis criteria, which is you need to dwell the fluids for at least 2 hours. If you have a patient who undergo frequent lavage in the peritoneum, that means if you're flushing the abdomen, then that also dilutes the cell count. And that's probably more important after you have diagnosed PD peritonitis and you want to see a response. And because sometimes we do peritoneal lavage to relieve the symptoms, and then you may have a false sense of security that the cell count is now getting better. So for APD patients, we tend to use the percentage of polymorphonucleosides, nuclear leukocytes, rather than absolute number of WBC to diagnose the peritonitis, and really a percentage of more than 50% is quite strong evidence of peritonitis. So for patients who are on APD, you might want to have a day dwell of at least 2 hours before you collect the cell count, and those without a day dwell, you should have at least 1 liter of dialysate infused for a minimum of 2 hours. The other thing that we want to really do when we diagnose PD peritonitis is we do want to get a positive culture. And that's important because that helps to guide our antibiotics treatment. It helps to give us an idea of what is the underlying cause for the peritonitis. And it minimizes antibiotic resistance because we are directing antibiotic treatment. So identification of the causative agents really requires appropriate culture techniques. And most of the time, it's a culture-negative peritonitis because the PD effluent was collected wrongly. And so we recommend that actually for every single patient who presents with a suspicion of peritonitis, the PD fluid should be sent in blood culture bottles rather than in sterile urine culture bottles, because that increases the risk of culture-negative peritonitis. And you need to work with your lab that the moment these samples reaches the lab, they should be processed as soon as possible and should not be left standing. Otherwise, if there's going to be a delay, like over a weekend, the culture bottles should be incubated at 37 degrees, or they should be plated quickly and then processed later. So if the culture-negative peritonitis rate exceeds 15%, I think the program would then have to review their processes and try to reduce that. So that's diagnosis of PD peritonitis. Let's talk about how do we prevent PD peritonitis, because that's the easier thing to do than to treat the patients when they come in with peritonitis. So we want to do it right at the beginning, so right at the start when we're going to put in a PD catheter. Just as an example, this is a country that I go frequently to consult. They bring me on rounds and they will present cases, difficult cases. And this is a 45-year-old gentleman who's an immigration officer. He developed 6 episodes of coagulase-negative Staphylococcus peritonitis and 2 episodes of culture-negative peritonitis just over a 3-year period. 5 of the episodes were associated with purulent discharge from the PD catheter exit site. And the patient is extremely keen to continue on PD. I will tell you that once you put a patient on PD, very few of them will want to be changed to hemodialysis. And the PD technique was assessed to be very, very good. So, and every episode responded to antibiotic treatment. So this is the exit site when I saw the patient and I was preparing to do a procedure. Anyone see there's anything wrong with this exit site? It looks really nice, actually. But what I have not told you is that the head is on top, the legs are below, and the exit site is literally pointing upwards. It's literally collecting any sweat that flows down and any dirt that flows down. And that's why it's actually often presenting with exit site infection and hence resulting in peritonitis. So this is a bad surgeon. So the surgeon should not have created the exit site that way. And so what we did, we made some incision, we shaved the cuff, and we translocated the exit site to make it face downwards. And since then, he had no further episodes of peritonitis for the next 4 years. So the first commandment of preventing peritonitis is to make sure that we have a good surgeon who put in a very good catheter and with a good exit site. So you want an exit site that is above, if the belt line is above the umbilicus, you want the exit site below the umbilicus. If the belt line is below the umbilicus, you want the exit site above it, because essentially you do not want the belt line to be rubbing against the exit site, causing abrasion and increasing the risk of peritonitis, exit site infection, and you want the exit site to be pointing downwards. The other thing, of course, is prophylaxis, antibiotic prophylaxis. So the ISPD guidelines have given 3 antibiotic prophylaxis recommendations. The one with the strongest level of evidence is recommending that systemic prophylactic antibiotics be administered immediately prior to catheter placement. That means the patient is on the table, you're about to make the incision, you give 1 dose of prophylactic antibiotics, and that's a very simple and cheap way of preventing catheter infection and peritonitis. However, this is not really practiced despite the fact that this is a 1A evidence. So if you look at the data from PDOPS, prior to PD catheter insertion, we have only Canada that does that 100% of the time, and UK that do it 100% of the time. And in places like the United States, only 63% of the time do people get prophylactic antibiotics, despite it being simple, cheap, and easy to give. So the other antibiotic prophylaxis recommendation was to give it before colonoscopy, an invasive gynecological procedure, as well as to drain the PD fluid to keep the abdomen empty before any endoscopic GI or invasive instrumental gynecological procedures. The other preventive measures is to really practice exit site care and exit site prophylactic antibiotics. So this is a study. These studies have been largely coming from Pittsburgh, from Beth Pirano's group and Judith Bernardini. So they have shown that with the reduction of Staph aureus catheter exit site infection, they have seen a concurrent and a parallel decrease in the Staph aureus peritonitis, suggesting that if we prevent exit site infection with prophylactic antibiotics, we can also prevent PD peritonitis. And again, this is a 1A recommendation by ISPD. They recommend daily topical application of antibiotic cream or ointment to the catheter exit site, but likewise being a high quality evidence recommendation, this is not universally followed. And again, this is a very cheap and easy way to prevent peritonitis. There are two other ways that we can consider preventing peritonitis. These are not as robust as the previous recommendation. One of which is to prevent the occurrence of hypokalemia, because we do know that with hypokalemia, there is issues with the gut, and there's a higher risk of Enterobacteriaceae peritonitis. And essentially, this is the hypothesis of why that might happen, that hypokalemia may result in decreased intestinal morbidity, as well as maybe causing maybe as a result of malnutrition. And this all results in bacterial translocation and increased risk of Enterobacterial peritonitis. The other recommendation that is seen in the guidelines is the use of histamine 2 receptor antagonists, such as famotidine. There is a meta-analysis that did suggest that the use of histamine 2 receptor antagonists may increase the risk of enteric peritonitis, but the use of proton pump inhibitors may not. So there is a suggestion that we should try to avoid that and maybe use PPI instead. So we prevent peritonitis. What will be the initial treatment of PD peritonitis? It's not difficult, but I think the key points that I think we want to highlight is that you want to collect the PD cell count, the PD fluid for cell count, differential count, gram stain and culture before you initiate antibiotics. And within the first 6 hours, you want to start IP antibiotics, intraperitoneal peritoneal antibiotics covering for gram-positive and gram-negative organism. And the suggestion is that you might use a first-generation cephalosporin or vancomycin for gram-positive coverage. You could use a third-generation cephalosporin or aminoglycoside for gram-negative. There has been a randomized control trial that shows the benefit of a monotherapy of a fourth-generation cephalosporin like cefepime. So these are what you would consider based on the microbial picture in your unit. And then you might want to consider adjuvant treatment such as peritoneal lavage to decrease the inflammation, the use of IP heparin to prevent fibrin formation. So these are other things that are already in the guidelines. Some slides and some thoughts about the use of antibiotics and whether we give intravenous or intraperitoneal. I think the recommendation is always to use intraperitoneal because this results in a high antibiotic concentration at the site of infection. And really, you do not need IV access, especially for patients with very poor venous access. And you could do this in the home and not have the patient being admitted, and can be given irrespective of GI symptoms. So, and we want to understand that if you have peritonitis, really the absorption of the antibiotics is significantly increased through the inflamed peritoneum. And so you do result in a substantial systemic antibiotic exposure. There is, most of the time, if the patient's on CAPD, we just need to give the antibiotics in just one dwell, with a caveat that there must be at least a 6-hour dwell for the antibiotics to achieve sufficient systemic exposure to the antibiotics. So just some nuts and bolts about antibiotic dosing. So the ISPD guidelines do give you a list of the antibiotics you could use, the loading dose as well as the maintenance dose. But what's important is that you do want to dwell for at least 6 hours. There is some discussion on continuous and intermittent dosing. I think if most of your patients are actually on CAPD, intermittent dosing in one exchange would be preferable. For APD, you want to instill it in the long day dwell versus continuous dosing during the night cycle. And really, you do not need to convert the patient to CAPD. The other thing to remember is to make sure that you have effective antibiotic dose. And so in patients who have significant residual kidney function, you want to increase the antibiotic dose by about 25%. So that's something to take note of. And then there is talk about using antifungal prophylaxis because with the use of antibiotics, you increase the growth of fungal organism, and therefore you may increase the risk of fungal peritonitis. And so it's a 1B evidence where they actually recommend the antifungal prophylaxis be co-prescribed whenever the PD patients receive an antibiotic course. Again, I think it will be something that you would have to decide in your program because I don't do it because I see very, very little fungal peritonitis and hence I do not want to increase the pill burden for the patient. And so subsequently, what do we do? Quickly, there are some peritonitis. So the general principle is you give the peritoneal antibiotics After about 3 days, when your culture is back, you then switch it to a very specific directed antibiotic. And most of the time, you give it, in the past, we talk about 14 days, but now the guidelines have suggested that most peritonitis, you give about 21 days with the exception of maybe coagulase negative staph and streptococcus, where you can give it for 14 days. But to highlight for gram-negative peritonitis, I want to highlight that Pseudomonas acinetobacter and Sternotrophomonas, they are very, very aggressive organisms, especially for Pseudomonas. It's difficult to clear, and the recommendation is that you should use 2 antibiotics that are sensitive to the organism, and that they all should be given for 21 days. If there has a polymicrobial peritonitis, you really need to make sure you're not dealing with a GI problem. You might want to consider a CT scan to make sure there is no underlying intestinal abnormalities such as an infection or perforation. And if you have culture-negative peritonitis, really if nothing to go by, so the decision is very dependent on whether the patient's improved with the antibiotics that you have. If they do, this is most likely going to be a coagulase-negative staph, and the recommendation is that you stop the gentamicin and continue with cefazolin for 14 days. If there's no clinical improvement, then you might need to consider other causes such as Mycobacteria or Legionella, and then if these are positive, you treat accordingly. If it's still negative, you may want to consider removing the catheter. Fungal peritonitis, the thing that we always tell the trainees is if you do see fungal peritonitis, to quickly arrange for catheter removal, because this is associated with high risk of mortality. And so catheter needs to come out, and then you treat according to the organism. Now, I just want to touch quickly on tuberculosis peritonitis, because this is common in many parts of Southeast Asia. In the past, it's recommended that catheter be removed, but however, there have been at least 2 studies to show that you could leave the catheter in place and the patient still responds and do well with anti-TB treatment. So the initial treatment should be with 4 drugs for a total of 2 months, and then you need to give rifampicin or isoniazid for at least a total of 12 months. And finally, when do you remove the catheter? The 4 R's, if you have refractory, recurrent, relapsing, or repeat peritonitis, it's recommended that the catheter is removed. You also remove the catheter for fungal and non-tuberculous Mycobacterium peritonitis. So to bring it all together, to finally summarize, the guidelines also recommend that every program should monitor on a yearly basis the incidence and the outcomes of peritonitis, and that these are the parameters that needs to be measured. We suggest that the rate of peritonitis be reported as number of episodes per patient year, and that this should not be more than 0.4 episodes per year at risk. If you have peritonitis rates higher than that, you should review some of the process in your program. And then reporting organism-specific peritonitis rates at absolute rates, and we should also make sure that the culture-negative peritonitis should be less than 15%. And with that, I thank you for your kind attention.